Hello, and welcome to the American Psychological Association's webinar on smoking in rural populations. This session is pre-recorded and archived on the APA website. Questions about the webinar series or suggestions for future webinars may be emailed to the staff of APA's Health Disparities Program. APA created the Health Disparities Program to expand and strengthen psychology's role in achieving health equity for underserved populations through dissemination and implementation efforts. One of our major initiatives addresses tobacco use in vulnerable populations, including today's session on smoking in rural areas. Our speakers will describe smoking rates and risks particular to rural populations, the interventions that have been shown to work in these areas, and activities designed to address smoking in rural Halifax County, North Carolina. Our first speaker will be Dr. Star Mitchell, staff nurse in surgical trauma intensive care at the University of North Carolina Medical Center at Chapel Hill. Dr. Mitchell will be followed by Ms. Belinda Jones-Hill, nurse and manager of critical care services at Halifax Regional Medical Center. And now I'll turn it over to our first speaker, Dr. Star Mitchell.
Good morning and welcome. I'm happy to have this opportunity to share this information to you about smoking in rural populations in North Carolina. I would first like to acknowledge a team of many of the researchers that shared in this research. Dr. Cheryl Giscombe and Dr. Sean Knight, both faculty members at UNC Chapel Hill. They assisted in much of the information that will be shared today. First, I'd like to recognize that how we define rural communities in North Carolina is somewhat of a problem, and the geographic areas that are identified as rural populations differ. For the purposes of this study, a geographic area is a small town or city that has a small density outside of cities, and it's comprised basically in this country of 90% of the landmass with 16% of the U.S. population. If we look at smoking in rural populations is twice the rate of Healthy People 2020 target. The target rate is 12%. We're seeing approximately twice that amount in our rural populations. It's higher in rural households when compared to suburban and urban households, and the age of initiating smoking is younger when we look at rural populations. Exposure to secondhand smoke is a problem at home and in work environments, and tobacco-related diseases are increased in rural populations where we see this higher rate of smoking. Rural North Carolina has 100 counties, or North Carolina, excuse me, has 100 counties. 80 of these are designated as rural, having an average population density of 250 people per square mile or less. And this is according to the 2014 U.S. Census population. In 2010, our rural data showed that approximately close to 5 million people lived in rural areas in North Carolina with a median annual household income of approximately, again, $41,000 a year. But yet the poverty rate is much higher in rural North Carolina, being 19%. Smoking in North Carolina. Nationally, our smoking rate has decreased now to 16.8%, and these are according to our more recently published CDC findings. However, in North Carolina, our average is 19.1%, and in rural populations, this has increased to 20.1%. In non-rural areas, it's 17.7%. Well, the concern here is that smoking rates in North Carolina are on the increase rather than declining. In fact, we've increased overall from 17.3 to 21.1%. For women, it's still increasing from 19.2 to 19.3, but we are seeing a slight decrease in smoking in men from 24.5 to 22.6%, which is interesting in that we're seeing women especially beginning to smoke at higher rates than men. So what are the risk factors? Well, in rural populations specific to North Carolina, our tobacco industry is targeting smokers, finding that if the picture that you see on your screen is actually taken from a gas station in a rural county. Advertisements are targeted towards rural populations, and much more leaflets and pamphlets are even in those areas. Family history of smoking is more prevalent in rural populations, and of course our socioeconomic factors, looking at low income, unemployment, lower educational levels, and fewer community audiences or community resources and public institution. Social support is high for smoking, and social networks support smoking also in rural communities. So again, what are the health concerns? Again, looking generally overall, cardiovascular disease is on the rise. Smoking is related to coronary heart disease, ischemic stroke. Type 2 diabetes is related to high smoking rates. Lung disease, including cancer, of course, COPD, and we have a major concern for upper respiratory conditions increasing in children and families that have smokers. We're also seeing higher low birth weight pregnancy births. We're seeing higher rates of sudden infant death syndrome, complicated pregnancies, and infertility, not just in men but in women. Dental health, we see higher periodontal disease, tooth loss, visual cataracts, and macular degeneration. So lots of health concerns. Rural populations, geographic isolation, just being in a rural area in itself limits access to medical services. You have less budgetary and resources for smoking, and the cost of nicotine replacement to rural populations is higher because they're more limited in their access to financial assistance. And something that we're really finding more and more specific is our stigma, or the stigma and shame associated with smoking. Even in rural populations, we have managed to stigmatize smoking to a point where people are not as eager to let people know they smoke, so they don't access resources. We need to look at funding, public awareness, community leader involvement, and target our interventions towards this group of people and offer low-cost comprehensive services that will help to get the people out of the shadows and into areas where they can access more services. And we need to find more opportunities to get personalized social support for these people. Effective interventions. What we have found is that healthcare providers can really provide effective interventions by letting people know what's available and how to access things like telephone hotlines, internet services, and just community support systems. We can increase smoking restrictions and help to promote motivation and self-efficacy. There are limited studies on rural smoking. We need to increase that because we do know that socioeconomic factors are important and make a difference. We do know that stigma and shame affect smoking coming out of those shadows. So we need to increase those opportunities that help people open up And now I'm going to turn our program over to Belinda Jones-Hill. Thank you.
Good afternoon, and thank you, Star. My name is Belinda Jones-Hill, and I am the manager of the intensive care unit here at Halifax Regional, and I'm a long-term resident of Halifax County. Today I will be talking about smoking prevention in Halifax County, and as you well know, it is a team approach, and we have many community partners who work with us diligently. Some of our community partners are the Roanoke Valley Breast Cancer Coalition, the faith-based community, which includes First Baptist Church of Roanoke Rapids, Halifax County Health Department, the Northampton County Health Department, Halifax Regional Medical Center, and the Gregory B. Davis Foundation. Halifax County is one of the largest geographical counties in North Carolina. We have approximately 54,000 residents. The median income here is $32,000. We have approximately 23% of our residents who live below the poverty level, and 17% of our residents are disabled and uninsured. One of the Halifax County have 100 counties, as Star stated. And one of the things that we look at are the health outcomes of each county. Health outcomes are the length of the life as well as the quality of life. But we know that quality of life and length of life is dependent upon our environment, our access to health, as well as our healthy behaviors. Halifax County is currently ranked number 97 out of 100 counties. Previously, we were number 99. Traditionally, 1 is great, 100 needs improvement. So you can see that Halifax County needs improvement as far as health outcomes are concerned. And we went to work on those activities. We developed an initiative called the Community Health Initiative that included many partners to promote active living and healthy behaviors. And I think that's what increased our numbers or our ranking. Halifax County's health indicators and health status show our leading cause of death. And when community agencies and government and all those entities who make major decisions in our county got together, they just decided on the top concerns, health concerns that face our community. And as you can see, it's heart disease, cancer, stroke, and respiratory disorders. But number 10 was smoking. But what we recognize is smoking affects all of these diseases. According to the CDC, 1 in 5 deaths is caused by cigarette smoke or secondhand smoke, leading to heart disease, cancer, and COPD. For the smoking trends in our county, this is some very interesting data. The community health assessment that is produced by the Halifax County Health Department asked a question: do you use any kind of tobacco? And the answer was no, 88% of the time. Which, if you think about that, that means, wow, we only have a 12% smoking rate in our county. So we look at our county or our region, which is Eastern North Carolina, and it was 20%. Well, in actuality, we have a 19% or near in that 20% range of smoking in Halifax County. So we have work to do to get to that baseline. Well, one of the things that we're doing to work on that is with our community partners, we decided we would have a couple of programs, one of which was the Great American Smokeout, and we partnered with the Gregory B. Davis Foundation and the Roanoke Valley Breast Cancer Coalition. And we had planned this great event. And a picture tells you 1,000 words. It rained that day. Our event was planned for the outside. We had planned to have smoke coming from the trash cans so that it would be a major eye catcher. But it rained that day. And what we found out in our lessons learned was that this event was held in the middle of a lobby, and many of our residents were shamed. They didn't want to use the service. And so on this particular day, we gave out Nicorette gum because our goal was to encourage them to stop smoking for a day, to put something in their mouth to fix their oral fixation. We were passing out apples. Of course, we gave literature and community resources for smoking cessation. I think we met our goal. We did have our awareness event. We had over 86 participants. We gave out over 60 replacement Nicorette gum. But what we found was that smoking was deeply personal to each individual, and that we had people who were closet smokers. They did not want people to know that they were smoking. So when they participated, they asked for products for a family member or a loved one, when in actuality they were the smokers. We used this information when we went over to our faith-based community, and this was a group of men. And one of the things that we did with them early on is we established consensus, and we let them know that smoking was, we encouraged them and let them know that we were not talking about them. We had a little poem we started out with, and it said that everybody is somebody to somebody, to let them know that we were only talking about the act of cigarette smoking and not their person. And we also established a consensus saying that the Surgeon General was correct, that smoking was harmful to your health. And after we did those two small things, we saw the increase in participation, and we saw that people actually wanted to stop smoking, had tried to stop smoking on numerous occasions, and would go back to it. So we worked with that. Now, when we went over to Northampton County's Health Department, they had a program that focused on youth and the impact that smoking had on dentition. So that was very important. And our participant was a high-risk group, which was African American teen males. The key points was that smoking cessation is hard, and that there will be times when you will try and try and try again, but you keep going. We did introduce Quitline NC to all of our residents, and that was a great component because it had a telephone component, an online component, and it gave them a personal resource. And we found out many of our residents did not know those what was available to them. That concludes my presentation, and I will send it off to Patty.
And Star, for describing your experiences in this field and for offering information on how to reduce smoking and tobacco use in rural communities. We have more information on smoking disparities and other health equity related topics on our website, including other webinars. Please feel free to contact us by email with any questions. We would also like to thank our speakers today, as well as our colleagues at APA, for their invaluable help on this webinar series. And we'd like to thank the organizations that have helped fund our work on reducing smoking disparities, the Agency for Healthcare Research and Quality, and the Smoking Cessation Leadership Center at UCSF. And thanks to you, our viewers, for your interest.